Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I will be discussing one of the very important cardiac emergency, that is the cardiac tamponade. So if you see the definition of the cardiac tamponade, what exactly it means? See, it is one of a life-threatening condition in which the pericardial effusion has developed so rapidly. Okay, so what happens in this individual? There will be development of the pericardial effusion. But this development of pericardial effusion, it is very rapid. Okay, and this pericardial effusion which has developed rapidly will cause the compression of the heart. Right, will cause the compression of the heart. And for the development of cardiac tamponade, the quantity of the fluid necessary to produce the cardiac tamponade may be as small as 200 ml. Right, the quantity of the fluid required for the development of cardiac tamponade is as small as 200 ml. But this fluid accumulation of 200 ml should be rapid, and for suppose if there is gradual accumulation of the fluid, right, what should be the quantity of the fluid that has to accumulate gradually for the development of cardiac tamponade? See, the quantity of the fluid that has to be accumulated gradually for the development of cardiac tamponade should be more than 2 liters. Okay, either 200 ml when the fluid develops rapidly, to as much as more than 2 liters in slowly progressive effusions when the pericardium has had the opportunity to stretch and adapt to an increasing volume. So if the gradual accumulation of the fluid occurs up to 2000 ml, it is only just, we call it as pericardial effusion. But if it is beyond 2000 ml, then the individual may progress to develop the cardiac tamponade. See, the difference between the cardiac tamponade and pericardial effusion is that in pericardial effusion or cardiac tamponade, in both of these scenarios, there is accumulation of the fluid in the pericardial space. But in cardiac tamponade, it is rapid accumulation of the fluid, whereas in pericardial effusion, it is the gradual accumulation of the fluid. That is what is the important difference between the cardiac tamponade and as well as the pericardial effusion. So, in case of the cardiac tamponade, what is happening? The fluid is accumulating rapidly within the pericardial space. So, thereby, what will happen to the intrapericardial pressure? So, intrapericardial pressure it is elevated. Okay, and how much will be that intrapericardial pressure being elevated is, it should be greater than it should be greater than 15 millimeters of mercury. So, when this intrapericardial pressure has reached to more than 15 millimeters of mercury, that will restrict the ventricular expansion. Right, that will restrict the ventricular expansion. So, because the ventricular expansion is being restricted, what will happen to the venous return? So, there will be also reduction in the venous return. And why there will be reduction in the venous return? Because when the ventricles are not able to expand properly, the atria cannot send the blood adequately into the ventricle. So, the atrial pressure will be elevated. So, when atrial pressure is elevated, then the venous return which has to come into the atria does not occur. It will be reduced. Okay. Now, so what will happen to the ventricular filling now? The ventricular filling also will be reduced. Right, the ventricular filling will be reduced. So now you have to understand that once the ventricular filling is reduced, what will happen to the stroke volume? Even the stroke volume is also reduced. Right, even the stroke volume is also reduced. So once the stroke volume is reduced, the cardiac output within the individual of cardiac tamponade will be reduced. Okay, and these patients, they may progress to the development of shock and as well as death may result. So that is the definition of, that is the consequences of the cardiac tamponade. Now, followed by that, what exactly are the etiologies which will cause the cardiac tamponade? So, if you take the etiology causing cardiac tamponade, that includes number 1, neoplasia. Okay, so that is the malignancies can cause the cardiac tamponade, right? Or it would be some idiopathic unknown condition, like for example, it could be secondary to viral pericarditis also. Right, viral pericarditis also, or it could be some non-viral infections, and these non-viral infections include tuberculosis. Right, these non-viral infections include tuberculosis, and apart from that, the intrapericardial hemorrhage with or without pericarditis. So even intrapericardial, right, intrapericardial hemorrhage with or without pericarditis, even this also contributes to the development of the cardiac tamponade. Now, apart from these, we also have some more etiologies which can cause the cardiac tamponade, and those some more etiologies include uremic pericarditis, right, uremic pericarditis, and followed by that any surgery, right, surgery of the heart or surgery of the pericardium. Even this can contribute to the development of the cardiac tamponade. And radiotherapy to mediastinal and juxtamediastinal lesions. Okay, so mediastinal and juxtamediastinal radiotherapy, then vasculitis. Right? So these are all the etiologies which can contribute to the development of the cardiac tamponade. Now, after having discussed about the basic definition and as well as the etiologies causing cardiac tamponade, let me discuss the pathophysiology. What exactly happens in these patients with the cardiac tamponade? So, right, before that, there is one important triad in cardiac tamponade that is called the Beck's triad. Beck's triad of cardiac tamponade include the options are hypotension, neck vein distension, paradoxical pulse, silent heart and tachycardia. So what are the three components of your Beck's triad you need to know? Okay, but before that, let me discuss the pathophysiology. So if you take the pathophysiology, in these patients with the cardiac tamponade, it is characterized by accumulation of the fluid in the pericardial space. So, right, you have accumulation, rapid accumulation of the fluid in the pericardial space. It might be due to various causes, whatever we have discussed. Now, this fluid which is accumulated within the pericardial space, what it will do? It will cause the elevation of the pericardial pressure. Right, this will cause elevation of the pericardial pressure. So once there is elevation of the pericardial pressure, the increase in intrapericardial pressure leads to reduced filling of the heart. So this increased intrapericardial pressure causes reduced filling of the heart. So this we have discussed in the beginning of the session as well. And you have to know what you mean by a word myocardial transmural pressure. So this is your myocardial, right? This is your myocardial transmural pressure. Now how do we calculate the myocardial transmural pressure? What exactly is myocardial transmural pressure? So how do we calculate this? This is the difference between the intracavitary pressure and pericardial pressure. So it is intracavitary pressure minus pericardial pressure. Now if you see this formula here, for suppose if the pericardial pressure is increased, what will happen to your myocardial transmural pressure? It is also elevated, and thereby the filling of the ventricles does not occur. So in patients with cardiac tamponade, because of the accumulation of the fluid in the pericardial space, there is increase in pericardial pressure. So subsequently there will be increase in myocardial transmural pressure, which will cause reduced filling of the ventricle. That is what will happen in patients with the cardiac tamponade. So now subsequently what will happen to the venous pressures? The venous pressures will increase. So the right atrial pressure is elevated, right? RAP stands for right atrial pressure, and even the left atrial pressure is also elevated. So as the right atrial pressure is elevated, what will happen to your jugular venous pressure? Right? Even the jugular venous pressure is elevated because right atrium is unable to send the blood into right ventricle. Subsequently, the jugular vein will not be able to send the blood into the right atrium. So the jugular venous pressure will be elevated. Okay. So that increased venous pressure may fill the heart and increased intracavitary pressure to some extent, but the transmural pressures will not allow to fill the ventricles. Okay, so that is a very important point you have to understand here. So despite increase in venous pressure, that means the preload, what will happen to your preload? Preload is nothing but your venous return. What will happen to your preload? The preload will be reduced, right? So even though the venous pressure is increased, but the preload is reduced. Why? Because the right atrial pressure is also elevated. So that will be the story on the right side. Now what will be the story on the left side? See, the left atrial pressure is elevated, right? And as the left atrial pressure is elevated, the pulmonary veins, they don't drain the blood into the left atrium. So subsequently, what will happen to your LA volume? The LA volume will be reduced. So subsequently, what will happen to your LV volume? Right, even the left ventricular volume is also reduced. So as the left ventricular volume is reduced, even the cardiac output is also reduced. Now as the cardiac output is reduced, even the blood pressure of the individual is also reduced. So these individuals with the cardiac tamponade, they have the hypotension. Now after having discussed about the pathophysiology, let me discuss what exactly is the Beck's triad. Beck's triad, it is that which is characterized by the presence of increased JVP, there is jugular venous distension, right? Increased JVP, right, where there is neck vein distension, right, where there is neck vein distension, and here it is non-pulsatile right here it is non-pulsatile increase in JVP, right? And second important point is that there will be decrease in the systemic blood pressure. So the individual will have the hypotension, right? The individual will have the hypotension, that is decreased arterial pressure. And if you take the heart sounds will be muffled. So they will have muffled heart sounds. So why is that they have muffled heart sounds? Because there is the presence of the fluid in the pericardial space. And because of the presence of the fluid in the pericardial space, the heart sounds, they get muffled. Okay, and this we call it as the silent heart. Right, this we call it as the silent heart. So this is what is the Beck's triad. Number 1, neck vein distension. Number 2, the hypotension. Number 3, muffled heart sounds, right, which we call it as the silent heart. And regarding the JVP, there are some important points that you have to know. So the JVP, first of all, it is non-pulsatile elevation of JVP. Right, non-pulsatile elevation of JVP. And the same non-pulsatile elevation of JVP, it is also seen in SVC obstruction. Right, it is also seen in patients with superior vena cava obstruction. And you need to know what will be the important JVP findings. The important JVP findings, they include absent Y wave. Right, there is absent Y wave. That will be the important JVP findings. Now, why there will be absent Y wave, why there is presence of X wave, all that we will discuss. Actually, if you take the JVP, the waves what we have in the JVP is A, C, X, V, Y. Out of all these, the Y wave will be absent. Then, yes. So Beck's triad of cardiac tamponade, it includes, options were hypotension, neck vein distension, paradoxical pulse, silent heart and tachycardia. So what will be the answer? Hypotension, neck vein distension and as well as muffled heart sounds or the silent heart. Then if you take the clinical manifestations, most of the patients with cardiac tamponade, they complain of the following manifestations. That includes development of dyspnea. So why is that there is development of dyspnea? That is because of increase in the left atrial pressure. So as the left atrial pressure increases, there will be also increase in the pulmonary capillary wedge pressure. And as the pulmonary capillary wedge pressure increases, there will be development of the pulmonary edema. And that is what is causing the dyspnea. And these individuals, they also develop fatigue. So why is that these individuals develops fatigue? That is because of decrease in the cardiac output. So once the cardiac output within the individual reduces, there will be decrease in the blood pressure as well. So thereby what will happen to the perfusion to the end organs? Perfusion to the end organs will be reduced. And that makes the individual to develop the fatigue. Then followed by that, because of the development of the pulmonary edema, right, there is also development of the orthopnea. So when these individuals lies down in supine position, there will be difficulty in breathing, and that makes the individual to have what is called orthopnea. Okay, so these are the clinical manifestations. Then followed by that, the typical JVP findings in cardiac tamponade: absent Y descent, prominent A wave, absent A wave, prominent Y wave. So just now as I was discussing that in these patients with the cardiac tamponade, the Y wave is absent. Okay, now the question is, why is this Y wave absent and why is the X descent being present? All that we will discuss. So first of all, you need to know what is this Y wave. See, Y wave, it tells you about the atrial emptying. right, Y wave, it tells you about the atrial emptying. So when does the atrial emptying occurs? The atrial emptying occurs mainly during ventricular diastole. Right, the atrial emptying occurs mainly during ventricular diastole. Now, let me tell you what exactly happens in diastole. So, during the diastole, the pericardial pressure, it remains elevated in cardiac tamponade. So, the pericardial pressures, it is elevated during diastole in patients with the cardiac tamponade. And how much will be that? It is greater than intracavitary pressure. Right, it is greater than intracavitary pressure. So because the pericardial pressure which is elevated is greater than intracavitary pressure, there is no ventricular filling during diastole. Right, there is no ventricular filling during diastole. So because there is no ventricular filling during diastole, what will happen to your Y wave? There will be absent Y wave. Right, there will be absent Y wave. So that is what will happen in these patients with the cardiac tamponade. So in cardiac tamponade in the JVP, the Y wave is absent. Then you take during systole, right? Let me tell you, in patients with the cardiac tamponade, X wave, it is present. Right, the X wave is present. Now what does this X wave tells you? That tells you about the atrial relaxation. Okay, now let me tell you what exactly is the hemodynamics of the cardiac tamponade during the systole. See, during systole, the decrease in the size of the heart due to ventricular contraction reduces the pericardial pressure. You see here. Now, during systole, right, during systole, what will happen is there is decrease in the size of the heart. You can observe that here because the ventricles, they try to contract. So there is decrease in the size of the heart. So during systole, when there is decrease in the size of the heart due to ventricular contraction, what will happen to your pericardial pressure? The pericardial pressure, it decreases. Right, pericardial pressure decreases. So in cardiac tamponade, the heart filling occurs only in systole. Okay, because during diastole, the pericardial pressure is very high. So the ventricular filling does not occur during diastole. But during systole, the size of the heart is reduced. So thereby what will happen to your pericardial pressure? Pericardial pressure decreases. So once the pericardial pressure decreases, during systole, the heart filling occurs. Right, the heart filling occurs only in systole. So the venous return in cardiac tamponade is unimodal instead of the normal biphasic mode. Right, the ventricular contraction causes the atria to relax. Right, the ventricle contraction is causing the atria to relax. Right, both the atria. So during ventricular contraction, the atria relaxes. So as the atria relaxes, there will be presence of the X wave. So X wave of the JVP is present, but the Y wave of JVP in cardiac tamponade, it is absent. So to summarize this, during diastole, there is no venous return. right? There is no venous return. Thereby, there is loss of Y wave on JVP. And there is also collapse of the right ventricular pressure during diastole. So, during diastole, there will be right ventricular collapse. Right, there will be right ventricular collapse during diastole. Then you take during systole. During systole, the venous return occurs for a brief period. Right, venous return occurs for a brief period, exactly at the start of ventricular contraction. Right, venous return occurs for a brief period at the start of ventricular contraction, thus preserving the exudate. Right, this will preserve the exudate. So please remember now, exudate or X wave will be present in cardiac tamponade JVP, Y wave will be absent in the cardiac tamponade JVP. Now, after having discussed about the JVP, if you see the pulse, Pulsus paradoxus is characteristic feature of constrictive pericarditis, cardiac tamponade, hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy. Let me tell you, Pulsus paradoxus, it is a characteristic feature of the cardiac tamponade, right? And in Pulsus paradoxus, what exactly happens? What do you mean by Pulsus paradoxus? So, Pulsus paradoxus, it is a characteristic pulse where there is decrease in systolic blood pressure more than 10 millimeters of mercury. Right, there is decrease in systolic blood pressure more than 10 millimeters of mercury during normal inspiration. Right, during normal inspiration. See, you take in a normal individual, right, in a normal person, during inspiration, the blood pressure falls. But how much it falls? It falls less than 10 millimeters of mercury. Right? During inspiration, in a normal individual, the blood pressure will reduce, but it will be only just less than 10 millimeters of mercury. But in patients with cardiac tamponade with Pulsus paradoxus, the blood pressure reduces more than 10 millimeters of mercury during inspiration. Right? And the paradoxical pulse often can be noted by marked weakening or disappearance of peripheral pulse during inspiration. So, during inspiration, what is that you will notice in patients with Pulsus paradoxus or cardiac tamponade is that you will observe weakening or disappearance of peripheral pulse. Okay, so that is what you will notice in patients with the cardiac tamponade. But let me tell you, this Pulsus paradoxus is not only seen in cardiac tamponade. There are many other conditions where you have this Pulsus paradoxus. That is, so this paradoxical pulse is not diagnostic of cardiac tamponade. It can occur in chronic lung disease, right? It can occur in acute asthma, right? It can also be seen in severe congestive heart failure and in some cases of hypovolemic shock. Right, in some cases of the hypovolemic shock. So these are all the conditions where you have the presence of the paradoxical pulse. But let me tell you, this paradoxical pulse or pulsus paradoxus, it is absent in massive pericardial effusion. Where can you have this massive pericardial effusion? You will have that in patients with hypothyroidism. So in hypothyroidism, where there is development of massive pericardial effusion, pulsus paradoxus is absent. Okay, right. Now, how will you diagnose this cardiac tamponade? So, diagnosis of this cardiac tamponade, it is by echocardiography. So, echocardiography, right. So, this will be the investigation of choice, right. So, what does the echocardiography shows? It will show you the presence of the fluid in the pericardial space, right. It will show you the presence of fluid in the pericardial space, that is one thing. And second important thing is, it will also show you diastolic collapse of the ventricles. Right, diastolic collapse of the ventricles. That is what the echocardiography in patients with the cardiac tamponade shows. Now, I'll just show you that. So, this will be echocardiography. So, this will be the fluid. Right, so this will be the presence of the fluid in the pericardial space. Right, so and you will also observe that the ventricles, they collapse during the diastole. Now, after having discussed about the echocardiography, now let me discuss the ECG in patients with the cardiac tamponade. So, the ECG in patients with the cardiac tamponade will be in the form of the electrical alternans. Now, what do you understand by this word electrical alternans is that, okay, first of all, what exactly you mean by this electrical alternans? It is the clinical scenario where there is alteration in the amplitude of the QRS complexes. Right? It is the scenario where there is alteration in amplitude of the QRS complexes. So, in these patients with the electrical alternans, you have the one wave will be of larger in amplitude and the alternate wave will be of smaller in amplitude. So, if you see this, this will be the ECG in patients with the cardiac tamponade. So, you can see, observe that here this will be the wave with larger amplitude and this will be the wave with the smaller amplitude. So, you have that larger and as well as smaller amplitude waves alternatively. That is what you will observe in patients with the cardiac tamponade and that is called as the electrical alternans. Now, why is that you will have the ECG of the following fashion? You will have the ECG of the following fashion because you have swinging of the heart within the pericardial space. So, the heart, it swings right, it swings back and forth within the pericardial space and that is the reason why you will have this electrical alternance. So, whenever the heart swings back, you will have smaller amplitude. Whenever the heart swings forward, then you will have the QRS complex of larger amplitude. So, this is what is nothing but your electrical alternance. Then, followed by that, you need to know that cardiac catheterization will also help in diagnosing the cardiac tamponade. Next, how do you treat these patients? So, let me tell you, these patients, they require an emergency pericardiocentesis. Right, they require an emergency pericardiocentesis and you can also do this echo guided. right? Preferably the pericardiocentesis is being done in the cardiac catheterization lab, but if the sources are not available, you can do the pericardiocentesis even echo-guided. And what are the various approaches, right? What are the various approaches by which you have to do the pericardiocentesis? See, pericardiocentesis, the approaches can be like, number one, the apical approach, then the parasternal approach, and then subxiphoid approach, right? And out of all these, let me tell you, subxiphoid approach must be carried out. Okay, so this will be, right, this will be the best approach method. Okay, and let me also show you the various equipment which are required for doing the pericardiocentesis. So yes, so these are all the various equipment which are required for doing the pericardiocentesis. I'll give you a brief detail about the procedure as well. See, with the help of the lignocaine, you have to induce the local anesthesia, right? And after inducing the local anesthesia, with the help of a 60 ml syringe and as well as 18 gauge spinal needle, you have to insert the subxiphoid area, right? So you have to insert the subxiphoid area with the help of the 60 ml syringe and 18 gauge needle, that is the spinal needle. And once you feel that, or once you make out that the fluid is coming into the needle, then immediately you need to pass the dilator. Okay, so actually you have to pass the J-tipped guide wire through the 18 gauge needle, and once the J-tipped catheter has entered into the pericardial space, take out the needle and then you need to put the dilator over the J-tipped catheter. And with the help of the dilator, we try to dilate that particular area where we have pierced. And after taking out the dilator, right, we have to take out the dilator, still that J-tipped wire is there in the pericardial space. Over this J-tipped guide wire, you need to pass the 8 French pigtail catheter, right, 8 French pigtail catheter, and that particular pigtail catheter is placed in the pericardial space, and through that pigtail catheter, the fluid is completely drained out in the pericardial space and thereby relieving the pericardial pressure. So once the pericardial pressure is relieved, the ventricular filling occurs and thereby the cardiac output will be maintained. So that is what is the procedure for doing the pericardiocentesis. And this pericardiocentesis, let me tell you, this will be the only treatment of choice, right? This will be the only treatment of choice in patients with the cardiac tamponade, right? Now, after doing this particular pericardiocentesis, right, with the help of the chlorhexidine, you need to do a dressing and then close the subxiphoid area, right? So, but in certain scenarios, like in case of tuberculosis or malignancy, we place that 8 French pigtail catheter for 1 or 2 days in order to see that if there is any recurrent collection, even that collection is also completely drained out. And subsequently, after waiting for 1 or 2 days, with the help of a 2D echo, you observe if there is any pericardial fluid in excess quantity. If it is there, just keep the pigtail catheter in the place, but if the fluid is not there in excess quantity, then remove the pigtail catheter, and with the help of the chlorhexidine patch, you need to dress that particular hole what you have created in the subxiphoid area. So that is about the procedure of the pericardiocentesis, and that will be the treatment of choice in patients with a cardiac tamponade. So to summarize cardiac tamponade, so please remember, in patients with cardiac tamponade, you have the presence of pulsus paradoxus, that is, fall in the blood pressure more than 10 millimeters of mercury during inspiration. And then in JVP, the Y wave will be absent and there will be presence of the X descent. There will be presence of the prominent X descent. And what about the Kussmaul sign? The Kussmaul sign is absent in patients with a cardiac tamponade. So Kussmaul sign, it is absent in patients with the cardiac tamponade. Right, and it is also absent in patients with SVC obstruction. Right, it is also absent in patients with SVC obstruction. And third heart sound and pericardial knock will be absent. Third heart sound, it is actually the feature of the congestive cardiac failure. But in these patients with the cardiac tamponade, the heart sound itself, S1, S2 itself is completely muffled. And what about the pericardial knock? The pericardial knock, it is absent in patients with the cardiac tamponade. Where do you see pericardial knock? You will have that in patients with the constrictive pericarditis. And ECG, if you see in these individuals with the cardiac tamponade, that will show you the presence of the electrical alternans, right? And the echocardiography, that will show you the presence of the pericardial effusion, and the right ventricular size is usually very small, and there will be exaggerated respiratory variation in flow velocity, right? Now, what will be the CT or MRI finding? The CT or MRI finding, that will show you the equalization of the diastolic pressures in both the ventricles. So, there will be diastolic collapse of both the ventricles. That will be the characteristic finding either in echocardiography or the CT or MRI, right? And let me just discuss some questions on the same topic of cardiac tamponade. So, all of the following may be seen in patients with the cardiac tamponade except the Kussmaul sign, Pulsus paradoxus, electrical alternans, right ventricular diastolic collapse on echocardiography. Let me tell you, the Kussmaul sign is absent in patients with the cardiac tamponade. So, in Kussmaul sign, instead of decreasing, the JVP increases during inspiration. Okay. So, what is Kussmaul sign? Kussmaul sign is increase in jugular vein volume during inspiration, right? That is what is called as Kussmaul sign. But what happens in a normal individual? In a normal individual, there will be fall in the jugular vein volume during inspiration, right? There will be fall in the jugular venous volume during inspiration in a normal individual. But in Kussmaul sign, there will be increase in jugular venous volume during inspiration. That is what you will observe in patients with the Kussmaul sign. Okay. And what are all the conditions where you will have the Kussmaul sign? Kussmaul sign, it is present in patients with the restrictive cardiomyopathy. Kussmaul sign, it is present in patients with the constrictive pericarditis. Right Kussmaul sign, it is present in patients with right heart failure. Kussmaul sign, it is also present in patients with the tricuspid regurgitation. So, these are all the conditions where you have the presence of the Kussmaul sign, right? Next, but in patients with cardiac tamponade and as well as in case of SVC obstruction, the Kussmaul sign is absent. Okay, that is a very important point. Yes, if you see the same question in a twisted manner, Kussmaul sign is not seen in the restrictive cardiomyopathy, constrictive pericarditis, cardiac tamponade, then the right ventricular infarct. So, just now I have discussed in cardiac tamponade and SVC obstruction, the Kussmaul sign is absent. Okay, next. All are the features seen in cardiac tamponade except raised JVP, Kussmaul sign, rapid Y descent, Pulsus paradoxus. So, Y descent is absent in patients with the cardiac tamponade, right? Next. Electrical alternans is seen in. So, electrical alternans is what? It is the ECG finding. So, where do you have electrical alternans being present? Right? Electrical alternans is present in cardiac tamponade, whereas in restrictive cardiomyopathy, constrictive pericarditis and RVMI, the electrical alternans is absent. But in restrictive cardiomyopathy and constrictive pericarditis, what will be the ECG finding is they will have low voltage complexes. Right, they will have the presence of low voltage complexes. Now, what do you mean by these low voltage complexes? Low voltage complexes means the amplitude of the QRS complex, right, the amplitude of the QRS complex, it is less than 10 mm in chest leads, right, less than 10 mm in the chest leads, and the amplitude is less than 5 mm in the limb leads. Okay, so that is what is called as low voltage complexes. Amplitude of the QRS complex less than 10 mm in the chest leads and less than 5 mm in the limb leads, and you will have that in patients with the restrictive cardiomyopathy and as well as the constrictive pericarditis. Now, you see the next question. A patient presents with engorged neck veins, blood pressure is 80/50 and pulse rate is 100 per minute. following blunt trauma to the chest. What is the diagnosis? Pneumothorax, right ventricular failure, cardiac tamponade and hemothorax. See, this is a classical case of the cardiac tamponade. So you will have all the, you are having all the features of Beck's triad except for muffled heart sounds. So what should be there in Beck's triad? There should be engorged neck veins and there should be hypotension. And that is following the chest trauma, right, which is suggestive of cardiac tamponade. Then why not pneumothorax? So let me tell you, in patients with the pneumothorax, it can also occur following the blunt trauma. But you have to remember that in patients with pneumothorax, the characteristic finding will be absent breath sounds. That will be the characteristic finding in patients with the pneumothorax, right? Presence of the hypotension may or may not be present. Yes, in patients with tension pneumothorax, you may have hypotension. But the presence of engorged neck veins, it may or may not be present in patients with the pneumothorax, okay? Right, so this is a case of the cardiac tamponade. So these are some of the very important questions, and one more clinical scenario I'll show you. Right. A young motorist suffered injuries in a major road traffic accident. He was diagnosed to have the fracture of the left femur and as well as the left humerus. He was also having fracture of multiple ribs anteriorly on both the sides. On examination, blood pressure was 80 by 60 millimeters of mercury and heart rate was 140 per minute. The patient was agitated, restless and tachypneic. Jugular veins were distended. Air entry was adequate in both the lung fields. Heart sounds were barely audible. Femoral pulses were weakly palpable, but distally no pulsations could be felt. On priority basis, the immediate intervention would be rapid blood transfusion, urgent pericardial tap, the intercostal tube drainage on both the sides, fixation of the left femur and repair of the femoral artery. So, all these are the events which have occurred following a major road traffic accident to the chest. So the individual is having, the hypotension is there and the jugular veins are being distended and heart sounds are barely audible. So these three are features of your Beck's triad which are seen in patients with the cardiac tamponade. And in cardiac tamponade, what is the immediate intervention which is required? That is urgent pericardial tap. That is pericardiocentesis has to be done on an emergency basis to save the individual. Okay, and rapid blood transfusion should never be done, because if you try to give more and more blood, there will be more and more development of pulmonary edema and the patient will further worsen. So you should not do a rapid blood transfusion in a clinical scenario of cardiac tamponade. See, what about intercostal tube drainage? Intercostal tube drainage on both the sides is done in case of the pneumothorax. But in this patient, if you observe, the air entry was adequate. In patients with pneumothorax, the air entry will be absent. But here, the air entry is being adequate. So that is the reason why it is not a case of pneumothorax and these patients does not require intercostal tube drainage on both the sides. And fixation of the left femur and repair of the femoral artery can be done in the later stages as well. That means after doing a pericardial tap, you can do the fixation of the left femur and as well as the repair of the femoral artery. So in this patient, what is that which is required on an emergency basis? That is urgent pericardial tap. So these are some of the clinical scenarios and as well as the discussion about the important topic of the cardiac tamponade. Thank you very much.